Good morning, everyone. The topic for today's class is the management of recurrent glioblastoma. So this is going to be the outline. To start with, we'll just go through the biology and the treatment of newly diagnosed glioblastoma so that we have a background as to how to go about managing a patient with recurrent glioblastoma. And in patients with recurrent glioblastoma, the aspects we'll focus on during this class is the pattern of care, in which patients local therapies like radiation and surgery are to be used, the role of systemic therapy and supportive care. So overall, among all the solid tumors, glial tumors are not the most common. They are rare tumors. Amongst adults, 12 to 15% of intracranial tumors are glioblastomas, and of all the astrocytic neoplasms in an adult patient, 50 to 60, that means if you have a patient who is over the age of 40, about 2/3 of the patient who has a glial tumor, it will be a glioblastoma. So we'll just go through the pathology and molecular subtypes just to give an overview, because it impacts the further treatment options and the prognosis in these patients. So this is just the gross pathology. They are very aggressive tumors, so they grow rapidly. So you will have a pseudocapsule. They are poorly delineated, and a lot of necrosis is seen because of the rapid tumor cell proliferation. And this necrosis is seen not just in this pathological specimen, it's also seen on radiology. So it's one of the factors which help us identify that it could be a glioblastoma on radiology itself. The older term was glioblastoma multiforme, which is not used commonly now. And microscopically, these are very densely cellular tumors with a lot of mitotic activity, microvascular proliferation, and necrosis. And as per the WHO classification, they are grade 4, which is the most aggressive grade of glial tumors. So glioblastomas can arise of two types. Mainly, there would be primary, that is usually what we see in older patients, or secondary gliomas, which were probably low grade 2 or grade 3 gliomas, astrocytomas, or oligodendrogliomas, which eventually at recurrence transform into a more aggressive secondary glioblastoma. Usually, since these lower grade glial tumors are common a younger age, the mean age of patients with secondary glioblastoma is younger, it's in the 40s, as compared to the ones with the primary de novo glioblastoma. In terms of prognosis, the secondary glioblastomas usually do better. They have more molecular markers with good prognosis, like IDH mutations, and they respond better to therapy. So this is just a diagrammatic representation of the pathways of how tumors originate, and this is a summary of the molecular biology. So like I said, low grade tumors, they have IDH mutations, most commonly ATRX if they are astrocytomas, and eventually they can evolve into secondary glioblastomas. Whereas in the older brain, these are the commonly seen mutations, such as receptor tyrosine kinase mutations like EGFR, PDGFR, TP53 loss, TERT mutations, and these are the common molecular profile for the primary glioblastomas. So based on gene expression profiling, they have come up with 4 subtypes, that is the classical, mesenchymal, proneural, and neural. Just to remember, not to go into detail, the proneural subtype are the ones which predominantly have these IDH mutations and tend to have better outcomes. This is the gene expression profiling picture. Like you can see here, in the proneural, IDH mutations are very common. In the neural and in the classical subtypes, a lot of the EGFR mutations, that is the EGFR variant 3 mutations, are seen. In the mesenchymal, you can see the NF1 mutation, which is very common. So just the impact of this molecular profiling and how it helps us clinically. Classical, mesenchymal, and proneural, neural without IDH, they're usually more aggressive tumors. Proneural with the IDH mutations, usually these are the younger age and might be the secondary GBM, which do better. So the other important molecular test in glioblastoma is the MGMT methylation testing. MGMT is simply an enzyme which basically takes part in DNA repair when any alkylator has caused DNA damage, and this is how it removes the methyl group and repairs this DNA. But if this MGMT enzyme is deficient, then the DNA repair is there is an interference with DNA repair, both through the DNA MMR pathway as well as other pathways, including the pole gene, and then this DNA does not get repaired. It's a both predictive and as well as a prognostic marker. Prognostic because MGMT methylated patients in many studies, it's not just with a particular drug, irrespective of the arm, irrespective of the use of temozolomide, have shown in multiple studies that they do better. The other thing is that MGMT increases the sensitivity of temozolomide because temozolomide is an alkylator. So if this enzyme, basically the gene for this enzyme gets silenced because of methylation of these promoter sites before the gene, it's an epigenetic event that happens. When the promoter gets methylated, the gene gets silent, and then you have lower levels of this enzyme. And so the alkylating drugs, the drugs like temozolomide, which are commonly used, they cause DNA damage, and that can't be repaired because the patient does not have enough levels of the MGMT. And this is increases the response to temozolomide, and that also contributes to better prognosis. So MGMT testing is done by PCR. We'll just briefly go through the clinical presentation. Typically presents either with the neurological deficit, seizures, or signs of raised intracranial pressure. And this is what is a typical presentation, which leads to an imaging being done and a diagnosis of glioblastoma made. Few patients, around 2%, may have hemorrhage and may present like features of an intracranial bleed or a stroke. So in short, a summary about how we go about treating newly diagnosed glioblastomas. So these are the NCCN guidelines. The most important factor which determines prognosis in a glioblastoma includes the KPS of the patient, that is the performance status, as well as the methylation and the age. So if a patient is fit and has an age of less than 70 years, the most aggressive and the current standard of care would be to undergo surgery, that is a maximal safe resection, and followed by adjuvant radiation with concurrent temozolomide and 6 cycles of adjuvant temozolomide. Also, there is an alternative electric field therapy that is not available in India, but is one of the recommended thing in addition to adjuvant temozolomide, is using TTF or tumor treatment fields, which we'll discuss later. It consists of using an electrode device on the scalp, which delivers alternating electric fields, and this helps in controlling the tumor. So this has been, this is the category 1 recommendation, and most commonly where in parts of the world where this tumor treatment field therapy is not available, standard radiation after surgery with concurrent and adjuvant temozolomide is the standard of care in both methylated as well as unmethylated patients. If it's an elderly patient with a poor performance status, then the question arises whether he will tolerate radiation followed by adjuvant and concurrent temozolomide. So some altered strategies like giving temozolomide alone, or just hypofractionated brain RT alone, or if the patient has a very poor performance status, only best supportive care. So this is what I discussed. This standard of care came after the EORTC NCIC trial, which was published in 2002 by Dr. Roger Stoop. With this trial established the role of temozolomide. Previously, temozolomide was not the standard of care. After this study, that became the standard of care in newly diagnosed glioblastoma, because there was a significant improvement in the progression-free survival, and also the overall survival at 2 years was significantly improved. But despite all this, we know that glioblastoma is a very aggressive tumor. Nearly all patients relapsed. A long-term follow-up of this trial, the URTC NCIC trial, they published 5 years data, which showed that at the end of 5 years, even in those who received temozolomide, only 10% were alive, and those who received RT alone, only 2% is alive. So we know that this tumor has a very dismal prognosis. So this is the study which I spoke about. There's only 10% and 2% survival in patients who don't receive adjuvant temozolomide. So in the first line setting, standard of care is maximal safe resection followed by adjuvant radiation, which is around 60 gray, which is given, followed by with concurrent temozolomide at the dose of 75 milligram per meter square throughout radiation. After a gap of 1 month, then there is the adjuvant temozolomide for 6 cycles. To improve outcomes, because we know outcomes are dismal, multiple strategies like using longer duration of temozolomide or using dose intense, instead of giving 5 days out of 28 days of adjuvant temozolomide, there have been studies which have studied 21 out of 28 days with adjuvant temozolomide. This is one of the study which studied patients who received extended temozolomide beyond the standard 6 cycles of adjuvant therapy and to look for improved outcomes, and there was no benefit specifically. Overall, patients who had a MGMT methylation did better, and patients without residual disease did better, which goes to show that in the newly diagnosed glioblastoma, both the extent of surgery and MGMT methylation are important prognostic factors. But the extension of 6 months of additional temozolomide in either of this group really didn't contribute to improvement in survival. So these strategies did not improve outcomes. So ultimately, the original stoop regimen remains the standard of care even after so many years today in the first line setting. Now, this is a recursive partitioning analysis for GBM, which was, this table shows it in the pre-temozolomide era, and these are the factors which actually determine the survival. So they divided into 3, 4, 5, and 6. The 1 to 2 are the lower grade gliomas. So age, performance status, like I already mentioned, the extent of surgical resection, the neurological function, these were the ones which determined outcomes. And they saw that if the young patient with a good performance status had a median survival of 18 months, and as the age increased and performance status dropped, then other factors such as surgical resection and the radiation dose were included in the analysis. And then we can see that the survival outcomes drop, especially in patients who are older than 50 with a poor performance status. And ultimately, at 2 years, only 4% of these patients survive. So this is in the temozolomide era, and it has definitely improved in the temozolomide era from 15 months to 21 months. Even compared to radiation with temozolomide and radiation alone. So again, temozolomide has improved outcomes, but as you can see, the older the patients with more neurological deficits and less resection, that is only biopsy as compared to a better resection, the survival comes down. So now we move on to the main topic of today's class, that is recurrent glioblastoma. So to summarize, one is glioblastoma is a rare but very aggressive tumor seen in adults. It's around 2/3 of the astrocytic tumors. First line therapy includes maximal safe resection, radiation, and adjuvant temozolomide for 6 cycles. Almost all patients are going to progress within about 1.5 to 2 years. So ultimately, we all have a significant proportion of these patients for whom we treat for recurrent glioblastoma. This was a small study done at our center to see what patients with recurrent gliomas or glioblastomas expected. And as we can see, like in most other tumors, both symptom control and improvement in the duration of life is important from a patient's perspective. And the figure on the right shows that nearly half the patients don't receive any salvage therapy at relapse. Usually it is because of the poor performance status and the general overall fitness of the patient. Important to note, another thing is that this is one of the tumors in which the second line therapy, many don't receive second line therapy because it is so aggressive and their fitness is, their performance status is so poor. So a small fraction only end up getting local therapies, that is re-surgery and re-radiation, and the rest of them, majority, end up on salvage systemic therapy. So to look at what is the approach to recurrent gliomas and how have people all over the world approached this tumor. So if you see, 50% treatment rate is not just in the Indian setting, which was shown in our center, but if you look at trials from across the world, like this was a pattern of care study from Australia, which showed again in theirs only 48% received treatment after first recurrence. And finally, received initial treatment and progression, ultimately went on to get second treatment. This reflects the data which is seen in our setting as well. So this is another study which is from the Netherlands. Similar results. Patients who had best supportive care had very poor survival. They didn't survive for more than 3 months. That was the median survival. Patients who received some form of treatment had survivals ranging from 7.3 months to 11 months for systemic therapy and surgery. And old age, multifocal lesions, and steroid use were associated with shorter survival. And again, nobody lived beyond the range of 6.5 months. So this was the median OS, which is similar to data from our setting. And this is a study from the US, which also again showed that those who had surgery lived longer Those who received therapy also received longer, but again the overall survival in the good prognostic groups was also only 10 months. So this brings us to the conclusion that we are dealing with a very aggressive tumor with poor prognosis. This is our data. Again, this shows best supportive care who had a survival of approximately 33 days, and this was the ones who received treatment, where the overall survival was roughly around 3 months. But in our data, this was a retrospective analysis. Different modalities, that is re-resection, re-surgery, and re-RT, did not really show a big difference. They were almost similar survivals. So how do you approach a case of recurrent glioma? So the most important thing, the prognostic factors of age, performance status, neurological function, and extent of surgical resection that determine the outcomes in the first line newly diagnosed glioma also define the outcomes in the recurrent setting, because these are the factors which are determine whether the patient goes for local therapy or does not go for local therapy. And if the patient has a poor performance status, lot of the wheelchair bound, so then you look at whether it is because of edema or steroid toxicities. If it is because of these, then you can shift the patient to bevacizumab, which spares steroids, and try. Otherwise, if he doesn't improve, then best supportive care. If this performance status is not because of edema related symptoms, then ultimately we know it is the disease which is so aggressive. So patient goes on to best supportive care alone. If the patient has a good performance status, very often young patients with the localized recurrence come with relatively few symptoms and a good performance status. Then you look at the pattern of recurrence. What is the site, whether it was in the previous radiation field or not, how extensive is the disease, and whether it is feasible to go for resurgery. If the patients go for resurgery, usually they also look for, at least especially in our center, whether re-radiation is feasible, because just doing a resurgery may not add to that much to the survival. So they look at both these factors and then consider resection in the very few well-selected patients. And if it's a diffuse recurrence multifocal, then it is usually systemic therapy or alternating electric fields, which is not available in our setting. So this is what is done, and very few patients go for re-radiation. So in the retrospective data that I showed earlier, we had a re-radiation rate of only around 3.4% and a surgical rate of around 11%. So hardly 23 patients out of 700 patients went for re-radiation in our case series. So you can understand that most of the patients relapse early within 18 months, and most of them are not fit for irradiation because the duration of relapse disease-free interval is so short, or the relapse-free interval is so short in these patients, that giving radiation within such a short time will lead to toxicities like radiation necrosis, which can lead to significant worsening of the patient's quality of life. So just an overview of how we approach, again, as discussed, diffuse or multiple, they are not fit for local therapy. So either clinical trial, salvage systemic therapy, or best supportive care. If it is resectable, then go for surgery. Unresectable or resectable, not recommended, again, salvage therapy or alternating electrical field therapy. These are the factors which I already mentioned: the progression-free interval, volume of the disease, whether it is in the eloquent part or the non-eloquent part of the brain, and that determines whether resurgery will significantly hamper the patient's quality of life, and what was the previous treatment received. And ultimately, in many series that have already shown, only 20 to 30% end up going for local treatment. What is the role of surgery? In select patients, second surgery is possible, or it might be just a biopsy for a diagnostic purpose, which is done less frequently, unless there is a very big diagnostic dilemma on whether it is radiation necrosis versus progression. But usually it is done for debulking of the tumor, where there is a lot of mass effect. But no one has defined what are the indications for patients for recurrent with recurrent disease, who should be the candidates. No trial or no formal criteria or guidelines are available. These factors, such as eloquent, non-eloquent, or the tumor volume or the progression-free interval, are just overall guidelines which are described in various studies. Many of them are case series. And in patients who are operated, it is just 8 to 12 months. That is also the data which is available, the OS data from multiple case series. So one of the negative prognostic factors which one study had reported, we already discussed the good prognostic factors, that is younger age, longer interval, and better surgical resection at the time of the second surgery. These are good prognostic factors. But one factor which was highlighted as a negative factor is ependymal involvement. And this was a negative prognostic factor. The ependymal involvement means the tumor is deeper seated, ependymal regions are involved, and these patients do poorly. Caution for patients who undergo resurgeries: if patients have received bevacizumab pre-resurgery, then there might be wound healing complications, so that has to be kept in mind. There is some data which shows some benefit with carmustine wafers at the time of resurgery. This was a study which was done, and but the benefit was in weeks. It was not a long-term benefit. So there is some evidence that carmustine wafers, which can be implanted into the surgical cavity at the time of resurgery, and this has also received FDA approval. It's followed in some centers, but it's not a routine standard of care at recurrence. Again, the other local therapy is re-radiation. A lot of the data for re-radiation, like resurgery, comes from retrospective and observational studies. One thing we must understand is that we cannot give the same 60 gray or 59.4 gray dose that is given at the time of initial diagnosis or initial treatment because of the risk of catastrophic radiation necrosis. It is usually smaller doses with very high precision techniques. After the radiation, oncologists especially review the previous radiation plan and see the field at that time. And some patients with small volume tumors and very good performance status may benefit with re-radiation. So that brings us to systemic therapy, and we know that most of our patients, especially at our center, invariably receive systemic therapy. These are the three drugs which are commonly used in day-to-day clinical practice, but there has been a lot of research on targeted agents with multiple phase 1, phase 2 studies, few showing modest benefit. Immunotherapy has also been explored. Important thing is, in all the clinical trials in recurrent glioblastoma are predominated by mainly negative studies in multiple modalities, whether it is cytotoxic therapy, whether it is various TKIs or immunotherapy. So this is what are the regimens that can be used: single agent bevacizumab, re-challenge of temozolomide if there is a significant time period between the adjuvant and the recurrence. Lomustine or carmustine, that is nitrosoureas, and PCB, small studies have shown it has a benefit. It also has a nitrosourea. And there is a phase 2 study which shows some benefit with the use of regorafenib. And there is some data which shows benefit with the combination of a nitrosourea with bevacizumab or TMZ with bevacizumab. In very select circumstances where you have like NTRK fusions detected, which is only seen in around 1 to 2% of patients with adult glioblastomas, may be seen a little more frequently in pediatric glioblastomas, but again very rare. NTRK inhibitors can be used. Rarely BRAF V600E are seen, especially in epithelioid histology glioblastoma. So we have tried BRAF inhibitors in a few patients, and there are early phase studies, but no phase 3 study has proven benefit. So we come to the first drug, that is bevacizumab, and these are the various studies which have explored the efficacy of single agent bevacizumab with combination. And the response rates, one thing to note about bevacizumab is probably because of the anti-VEGF effect and the normalization of tumor vasculature and the decrease in edema, the response rates were in all studies, you will note, are significantly higher than what you see with cytotoxic chemotherapy. But that doesn't really translate into survival benefits. PFS ranges from 1 month to 4 months, and a 6-month PFS rate is around 29 to 40%. And the OS is similar to what is seen with other therapies. But this is one of the treatment options that can be used. Then people explored the role of combining bevacizumab with alkylating agents, that is CCNU. So this was one of the phase 2 early studies that was done, which evaluated bevacizumab, CCNU, and the combination of both. And they had an endpoint of 9-month overall survival. So they saw how many patients had lived up to the 9-month endpoint. And what they realized is the combination definitely improved outcomes. The dose they used was 10 mg per kg of bevacizumab and CCNU of 110 mg per kg. And initially in the safety part of the study, they saw that a lot of thrombocytopenia with the CCNU prevented the bevacizumab administration. The dose intensity was affected. So then they decreased the dose to 90 mg in the combination. And the combination did better. The CCNU single agent and the Bev single agent was similar in terms of the 9-month overall survival rate. And the median overall survival for both the single agents of both 8 months. So this is a large phase 3 study which explored the similar concept, that is combining bevacizumab with lomustine, and it was compared to lomustine alone and after progression at the first progression. So most of the studies which evaluated bevacizumab are including patients at the first progression. So these are the ones which had progressed after initial chemo surgery followed by chemo radiation, and then went on to receive either lomustine with bevacizumab or lomustine alone. And this study ultimately showed that the combination had a benefit for progression-free survival, which was almost 3 times that of giving lomustine alone. But when they went on to overall survival, there was no significant difference. It was 8.6 for CCNU and 9.1 for the combination of both. And this reason for it is not very clear. Toxicity, of course, with the addition of bevacizumab, thromboembolic events, hypertension was significantly increased in the bevacizumab plus lomustine group. And there was a 1/3 of the patients who had received lomustine went on to receive bevacizumab in the subsequent line. Whether this contributed to the negative OS is not clear. So anyway, based on this study, bevacizumab was approved in by the FDA for the use in recurrent glioblastoma. These are the outcomes with bevacizumab in our setting. Around the median survival will be around 4 months with patients, progression-free survival. And this is the overall survival in our setting. And then we come to the important aspect about the dose and the frequency of bevacizumab. So the initial dose that was used in these trials were 10 milligrams, but subsequently multiple people around the world in smaller phase 2 studies have used doses from 5 to 15 milligram, adjusting the frequency, making it 15 milligram 3 weekly or 5 milligrams every 2 weeks. And what they have noted is there's no great difference in the dose, whether you give 5 milligrams or 10 milligrams. Also, nobody has formally done a dose response assessment as to the benefit of increasing dose of the bevacizumab and the survival. So there is no data to determine what the dose is, and multiple studies have evaluated, small studies, the concept of lower doses of bevacizumab, like less than 5 or less than equal to 5 milligrams per kg. Also, low dose bevacizumab with immunotherapy is also a study that is ongoing. So the dose of bevacizumab, 10 mg per kg, probably is not the only dose that we can use. And this was also shown by a study at our center where we used a low dose bevacizumab. This is a retrospective study for patients who had dose of bevacizumab less than 5 mg per kg and comparing it to the standard dose. And we saw there was no difference in the PFS, no difference in the OS. So this reflects the data from around the world. So the dose of bevacizumab is not established. Based on the URTC trial, we use 10 mg per kg, but lower doses like 5 mg per kg can be used, or even less frequent dosing might be acceptable. This was some data from our center on whether biosimilars or innovator makes a difference. It did not make a difference in overall survival. And other than Avastin, which was the innovator, there are other biosimilars that have also got approval from the FDA for various indications. So the biosimilar bevacizumab seemed to work as well as the innovator. Next, we come to the cytotoxic chemotherapy, which is most commonly used in the real world setting, that is nitrosoureas. They have been assessed, carmustine, lomustine, as well as fortemustine have been assessed. And the range most commonly used is lomustine in various studies, like I had shown earlier as a comparator arm. The progression-free survival ranges from 1.5 to 2 months, and the overall survival ranges from 8 to 10 months in different studies. The dose for single agent is 110 mg per meter square. It's given 6 weekly. They always advise to cap it at 200 mg. The significant problem with CCNU is the hematological toxicity, which is there. Also, we often tend to think that oral chemotherapeutic agents are not emetogenic, but it is important to remember that both temozolomide and CCNU are highly emetogenic, and we need to give appropriate anti-emetic prophylaxis to these patients. PCV was studied in a study in high-grade gliomas at first recurrence. It was a phase 3 study and compared to temozolomide, but there was no significant difference whether we use PCV or temozolomide in this setting. But since PCV has shown benefit in patients with 1p19q co-deletion in the first line setting also, it may be considered as a salvage option in very fit patients in this setting. This is our data with CCNU, which is a small case series which was initially published, and even we saw 1/3 of the patients had significant myelosuppression, that was grade 3 or 4. So again, temozolomide is studied in multiple phase 2 studies. We can re-challenge it in significant number of patients if the duration after treatment is after more than 3 to 6 months. And usually these are better tolerated with less myelosuppression and hematological toxicities. So these were our PFS and OS with the temozolomide when we had used it in our center. A median in the MGMT methylated patients, they did much better. They had a PFS of 17 months and OS of 25 months, but the ones without methylation, they did poorly. So the third modality that has been used in this tumor is tumor treatment fields. We know that tumor treatment fields in the newly diagnosed setting, when it was added to the standard of care, it improved outcomes, and it is one of the standard options recommended. But the data for the recurrent setting is not as strong as that in the standard setting. However, there is it can be considered as an option, especially in patients who have progressed on multiple lines. So what are tumor treatment fields? It is alternating current or electric fields which are generated around the patient's tumor. These are electrodes which are attached to the scalp, and there is a transducer kind of a device which is attached to the patient, and the patient has to wear this for around 18 hours a day continuously. The scalp has to be shaved, and this electrodes have to be applied to the scalp throughout, and there can be some difficulty in patients who have poor performance status, cognitive impairment because of the neurosurgery, or any deficits who may not be able to manage these devices. The mechanism of action is basically because of the electric fields which are generated, which are the tumor treatment fields. The predominant target is the mitotic spindle, and the tubulin is charged, and when these fields are generated, it causes the interruption of the mitotic spindle, and it inhibits cell division in the metaphase. Also, there is some impact on DNA repair, and ultimately these cells end up undergoing autophagy. So this was the study which studied it in recurrent setting. This were like heavily pre-treated population. So they had already received 2 lines or more of therapy. 20% had already received bevacizumab. And it was compared to physician choice therapy. When it was compared to physician choice therapy, it did not change the OS or the PFS so much. So it did not add an advantage. But if patients have already received more than 2 lines of therapy and are fit, it could probably be an option in the 3rd line or 2nd line setting in patients who can access this device. The overall response rates were slightly higher than chemotherapy. It was 14% versus 10%. So we have seen three modalities, that is the use of VEGF targeted drugs, bevacizumab. Then we have gone through cytotoxic chemotherapy, CCNU and temozolomide, and then other mechanisms such as using alternating electric fields. But in all these 3 things, we know that ultimately there is a limit. Even with the use of aggressive combination therapy, survival in the recurrent setting is still around 10 months to 11 months, not more than that. And very few patients ultimately reach to the 2nd line therapy or post 2nd line therapies. So a lot of new agents have been investigated. And if you look at this chart of 10 to around 11 years, you can see that there are so many drugs, including bevacizumab, cediranib, enzastaurin, nivolumab, a vaccine also, which was developed, a peptide vaccine, which has been studied. And ultimately, a significant number of these patients have been on negative phase 3 trials, because most of these trials in various settings have not shown a benefit. So we'll just discuss few of the important trials, even though they are negative, but certain important modalities which might develop in the future. One is the immune checkpoint inhibitors. Immune checkpoint inhibitors have shown success in multiple tumors and have even significantly altered outcomes, but in glioblastoma, the results have not been so encouraging. The only setting in which it has shown some promise is the neoadjuvant setting, and studies are still underway. But in the newly diagnosed setting, where it has been tested with chemoradiotherapy and temozolomide. It has not shown benefit. In the recurrent setting, it has not shown benefit. So there are multiple reasons for that. What is the main reason is that immune milieu or the immunosuppressive environment of glioblastoma. It is a cold tumor in terms of immunologically. It is also a sanctuary site which is probably not exposed to the immune system so much. A low tumor mutational burden in this tumors, very few T cells, especially cytotoxic T cells in the tumor microenvironment, low PD-PDL1 expression, and a lot of heterogeneity in the tumor antigens. They lead to poor responses to immune-directed strategies. So even immune checkpoint inhibitors and some immune vaccines have failed and not demonstrated a significant benefit. So this was a Checkmate 143 study, which was the large study done, and ultimately it was a negative study. So this paper was the initial results of the Checkmate study, where they did a small phase 1 cohort and they checked 3 arms. They checked nivolumab 3 mg per kg, then nivolumab 1 mg per kg with ipilimumab 3 mg per kg, and then nivo with 3 mg per kg and ipilimumab 1 mg per kg. And then they saw the median OS, and they had a cutoff of the OS, and the single agent nivolumab was 40%, the others were 35 and 30% for the 9-month cutoff. So they used nivolumab in the subsequent phase 3 arm of the study as the experimental arm. And this was the Checkmate 143 study, and this was the experimental arm, and BEV, the standard dose of 10 mg per kg was the control. And patients who had first recurrence were taken into the study. And though again, like the URTC study, there was some PFS benefit. No, there was no PFS benefit. Actually, bevacizumab did better. And again, there was no OS benefit by addition of nivolumab. And this was a negative study. What they also showed is that the nivolumab patients did poorly. They also required higher larger number of patients required corticosteroids to manage the symptoms. Whether this interfered with the efficacy of immunotherapy is not known, but this was one of the negative prognostic factors. There is some evidence to suggest the use of pembrolizumab in glioblastomas who have microsatellite instability. But again, there is a limitation, is that the number of patients with gliomas who actually have MSI high are very low. So very few patients are eligible for the use of pembrolizumab in this setting. This slide appears crowded, but this is just to show you that the number of studies that have been conducted or are ongoing to evaluate immunotherapy. And so far, we have not got any promising results except some data in the neoadjuvant setting, which is also needs to be explored in larger studies. So in recurrence, there was no benefit. Recurrence with MSI, very few patients are eligible, but it might be beneficial. In the upfront setting during adjuvant chemoradiation, it is failed, and neoadjuvant needs to be studied further. So immune checkpoint inhibitors have still not become a part of the standard management of glioblastomas, even in the recurrent setting. The other immune-mediated therapies that were explored were vaccines, multiple studies, marginal benefits in some studies, but ultimately when they moved on to phase 2 and phase 3 studies, they failed. But there is some discussion that dendritic cell vaccines have shown some benefit, and they could be used as adjunctive therapy, but as a single mode of immunotherapy, none of them have shown any benefit, so they are not recommended in the standard of care. CAR T cell is another immune strategy that is being evaluated in phase 1 trials only. So far, phase 1 and 2 trials. Some studies showed 1 or 2 patients with stable disease and some benefit. However, there was, again, when they studied it in more patients, it was not sustained amongst all patients. And what they many studies report is that because of the tumor heterogeneity and tumor specific antigens which need to be recognized by the CAR T cells should be sufficient and the expression should be stable. Some studies where EGFR variant 3 targeted CARs were used, they found that the loss of the EGFR variant 3 expression led to the failure of this CAR therapy. So this is a major limitation. Some HER2 targeted CARs showed some benefit in some patients, but it was not sustained. We don't have the full results of these studies. So in the future, these therapies may be developed for glioblastoma, but we still need to await the results of all these ongoing studies. Regorafenib is a VEGF targeted agent. So this is one of the drugs that has a small phase 2 study which shows some benefit. So that is the reason I've included it. The target or the concept again would be targeting the VEGF pathway, though it's a multi-kinase inhibitor. And they compare it to against CCNU, which is often used as the control arm in most studies, where regorafenib was given 160 milligrams 3 out of 4 weeks, and CCNU was given on day 1 every 6 weeks. And the primary endpoint was overall survival. And these were again patients with first progression, not subsequent progressions. And this was the outcome. This was the median overall survival with regorafenib. It was 7.4, and this was 5.6 with the CCNU arm. And the 12-month was 38% versus 5%. So it was more than double of the CCNU arm. And this is the progression-free survival chart. So they did a post-hoc subgroup analysis. It seemed that most groups may develop a benefit, MGMT, methylated, unmethylated, as well as whether the patients underwent surgery or not. These are the response rates. Response rates are not that dramatic. Most patients had stable disease. However, despite this, there was a benefit over CCNU. Toxicity of regorafenib is well known, including things like hand-foot syndrome, which is seen when regorafenib is used in other malignancies. So there is an improvement in overall survival. PFS also was improved. Safety is expected, like what we usually see, but we need to see phase 3 data, which is ongoing. There's a study which is ongoing with the use of regorafenib in the phase 3 phase 3 design. Many other drugs have been tried. Other targeted agents which I've just mentioned here is palbociclib, ribociclib, which showed no efficacy. PIK3CA inhibitors, which are also not shown any benefit. Olaparib has been recently presented in last year's ASCO in IDH mutant patients. Again, there was no significant benefit, and this was the PFS which they had of 31% for 6 months, and it did not reach their preset set point. And they said it might have some activity in heavily pretreated IDH mutant high-grade gliomas, but it was not sufficient as a single agent therapy alone in this group of patients. So maybe they suggested that maybe combining it with chemo might be a more effective strategy, but we still have to wait for results if any such trial is ongoing. And before I end, we just come to the last part of the discussion, that is the discussion on mebendazole, which is the repurposing of this anti-helminthic drug, which is being done at our center. So mebendazole is an anti-helminthic drug commonly used for deworming, especially in the pediatric age group. And both mebendazole and albendazole have been studied in cell lines, and they have shown in glioma cell lines improved they have shown activity in glioma cell lines with significant CNS penetration. So early phase studies were done, and we also conducted a phase 1, phase 2 study, which is nearly complete. 2 arms are completed, 1 is still ongoing. And the aim of this study was to use mebendazole along with standard chemotherapy. It was not a single agent. It was combined with either CCNU or temozolomide, which is the commonly used standard of care at our center. And in patients who are fit for local therapies, that is either resurgery, re-radiation, we had a re-radiation arm where temozolomide with RT was given and mebendazole was added to the same. This arm is still ongoing. So first it was a phase 1 design that was done to determine the dose for phase 2. This was the 6-month PFS and the phase 1 patients, that was around 12 patients, and the 6-month OS. And this was published. And then now the phase 2 component has nearly been completed. The dose for phase 2 was 800 milligrams in combination with CCNU. This 800 milligrams of mebendazole is given thrice a day. It's been chewed. It has to be chewed with meals, and CCNU is given at the standard dose of 110 mg every 6 weeks. And for temozolomide arms, that is both the re-RT and temozolomide arm, as well as the single agent salvage temozolomide arm, it was 1600 milligrams. So 1600 milligrams 3 times a day, and temozolomide at the standard dose of 150 mg for the first cycle and 200 mg for the subsequent cycles. And we are just analyzing the results of the phase 2 part of the study. Except for the re-RT arm, the other 2 arms are completed. So we will get the results shortly. And if this drug shows benefit, then it could be used as a combination or an adjunct to the standard alkylating agents like temozolomide or CCNU. Now, the most important part in glioblastoma, which is to be remembered, is supportive care. Supportive care efforts are much more in neural tumors as compared to other malignancies, because the patients, even at baseline before recurrence, may have a poor performance status because of neurological deficits. Some aspects of supportive care include managing the distress, giving counseling the patients for compliance to therapy. Also, when we give therapies such as bevacizumab, we need to monitor for blood pressure, urine protein, the 2D echo. Temozolomide, CCNU, appropriate antiemetics need to be given. A lot of patients are already referred to the occupational therapist at time of diagnosis, but if patients are ambulatory and have minor deficits at time of recurrence, we should also make sure that these patients are referred for occupational or physiotherapy, and counseling for adherence to whatever therapy that they are given. We all know that patients with recurrent glioblastomas will have significant distress. This was a data published from our center, which shows that distress score of 4 or more was seen in 61%, 61.9, that is 2/3 of our patients. And this contributes to significant issues with the patient and compliance with therapy. I already discussed about antiemetics. Another important thing that we should know if we are putting patients on drugs like temozolomide is giving prophylaxis for PCP. That should be given in such patients. So with this, come to the end of the discussion. To summarize, glioblastoma is a rare but aggressive tumor with very poor outcomes. 5-year survival less than 10% in patients who have received the standard of care, even in the current era. The outcomes for recurrent glioblastoma are dismal. Important to note that 50 to 70% of patients never get any treatment at the time of recurrence. There are some drugs which have shown modest benefit in patients with recurrence, may helps in relieving symptoms and a modest improvement in survival. However, that is also a very small small duration that ranges from 6 to 8 months in the commonly seen, and more drugs are being evaluated, but because of the nature of the tumor, the location within the CNS, the poor immunogenicity, there have been lot of obstacles to develop new therapies. So multiple strategies have failed. So to remember, if a patient comes with the recurrent glioblastoma, first thing we look at is what is the prognostic factors like age, performance status, the progression-free interval from initial therapy, what is the whether the patient is fit for local therapy, where is the location of the tumor, and whether it's feasible for re-resection, whether patient can go for re-radiation. If these strategies are amenable, then we should refer the patient for the same. If most of the patients will not be fit for these because they relapse within 18 months and end up on salvage therapy. So again, based on the patient's fitness or affordability, we have the option of giving a combination of a VEGF inhibitor like bevacizumab with CCNU in a fit patient, or single agent of bev, CCNU, or temozolomide. In patients who have access to tumor treatment fields and have failed all these other lines of systemic therapy, we can offer that. But again, we have to explain to them that the outcomes are limited. Supportive care is an important component and it should not be missed. So with this, I'll end my talk. I'll be happy to take any questions. There are 2 questions in the chat. So the response rate of bevacizumab, and when do we use bevacizumab with irinotecan? So the response rates of bevacizumab, like I've shown, ranged from, in some studies, from single agent from 20 to 23% to up to 35 to 40%. But the response rate of bevacizumab doesn't usually translate into overall survival benefit, though it definitely improves the patient's symptoms, especially in patients who have a lot of peritumoral edema. Resurgery is not possible, mass effect is there, and they are steroid dependent. In these patients, bevacizumab helps a lot in decreasing the edema and helping in patient symptoms. When do we use bevacizumab with irinotecan was used initially, and there was a 2 to 3 month benefit. We commonly don't use bevacizumab with irinotecan at our center. We usually combine it with CCNU. Here, the when to use PCV in recurrent glioma, the recurrent glioma, the PCV is commonly used in a patient usually who has, we suspect, a transformed oligodendroglioma with 1p19q deletion, and those are the patients who are likely to respond. But the other factor that limits the use of PCV in recurrent gliomas, one, it has not shown overall survival benefit in the phase 3 study that showed that compared it to temozolomide. So there is no extra advantage. Second is PCV is very toxic in our low-grade gliomas. Even in the trial setting, a significant number of patients get hematological toxicities, and there are a lot of dose delays and interruptions. In the recurrent setting, patients' baseline performance status and many patients are not fit. Many patients are wheelchair bound. So giving all these patients PCV without a proven survival benefit may not be worth it. So probably those who have 1p19q and who are fit would be the select candidates for using PCV.
Nandini, just to add there, if the patient has 1p19q, according to the recent WHO, it won't get classified as a GBM. It would stop at a grade 3. So with respect to current classification, PCV would have no role. Because if it is 1p19q, you won't put a oligodendroglioma as grade 4. You would always put it as a grade 3.
Yes, sir. So there is a question by Madam on the mechanism of action of mebendazole. Would you like to take it?
Yeah, I'll take that. So the mechanism of action of mebendazole is anti-mitotic activity, and it has been shown in cell lines to have glioma cell lines to have anti-mitotic activity. Along with it has some amount of anti-angiogenic property also. The thing is that mebendazole comes into 3 isoforms, A, B, and C. It is the C isoform which has the best penetration in the CNS. So it's said that if you use the C isoform for anti-helminthic treatment, you will get more of a neurological side effects because the CSF to plasma penetration ratio for the C isoform stands at around 0.7 to 0.8. So it has a very good penetration. So, but this is the isoform which is the best for use in glioma. Unfortunately, in India, we don't get the C isoform. What we get is the B isoform, and the B isoform still has a good CSF to plasma penetration, which is around 0.67. The A isoform is the one which has the least penetration in CSF, which stands around 0.4 to 0.5. The study which we did was with the B isoform because C isoform was not available to us. And the mechanism of action is anti-mitotic and to certain extent anti-angiogenic property with mebendazole.
Thank you, Vijay. That's very interesting.
Then there's another question on deciding whether 6 months versus 12 months of temozolomide. In the study that studied 6 months versus 12 months of temozolomide, that was a Geno 1401 study, they didn't find any benefit of giving those additional 6 months. So as standard of care, we give only 6 months of temozolomide. But some other data especially has suggested that in MGMT, you could try giving 12 months of temozolomide, but there's no evidence. And this study has definitely shown that in the MGMT group also, though they had a better survival than non-MGMT methylated, adding temozolomide for another 6 months did not improve survival. So as a standard of care, 6 months of temozolomide in the adjuvant setting is the recommended duration. So would you like to add to it, sir?
So what you said is perfectly correct. The Italian study was very clearly designed for this. It was a Spanish study. They took patients who had completed 6 cycles of temozolomide, who had not progressed, had tolerated it well, and then randomized to additional 6 cycles of temozolomide versus observation alone. And what they saw was additional 6 cycles of temozolomide, irrespective of whether it was MGMT methylated or not methylated, did not lead to any overall survival advantage. So at current standards in adjuvant setting, I agree with you, Nandini, it's best to stop at 6 cycles. Saying that in salvage setting, when you're giving a re-challenge with temozolomide, it may be a worthwhile to go for 12 cycles or actually go till the patient does not have intolerable side effects of progression.
Thank you, sir. The next question is, what DFI can be re-challenged temozolomide at recurrence 6 or 12 months? So at what DFI, nobody has defined the DFI, but what we have commonly used in our trial setting and in clinical practices, if at least there is a 3-month interval from the previous temozolomide dose, then we could consider these patients. The longer the DFI, probably it would be better, but we used a duration of 3 months in the trial setting. Sir, would you like to add?
Yeah, I agree with you. Normally, so the 3 months DFI means that it is 3 months from the last dose of temozolomide. But the best results you get when the DFI is beyond 12 months. So the results which Nandini showed for re-challenge of temozolomide, those were for patients who were carefully selected with a DFI more than of 12 months. The problem is, if you go for a DFI greater than 12 months, you would hardly get any GBM which is fitting into that criteria. The most of the times your data series will be of consisting of secondary GBMs or anaplastic astrocytomas who are IDH mutated who have longer PFS. Even in the STOOP study, the PFS was around 6 to 7 months, and by the end of 1 year, only 30% patients go beyond 1 year. And the calculation for PFS in the STOOP study was done from the date of randomization, that is date of start of radiotherapy. So if you see, pull out 2 months for radiation and 6 months of temozolomide, so 8 months. So within on treatment progression, most of your patients will be in GBM, will be on treatment progression. And even if you add 3 months beyond that, that is 11 months, then you would have only 30% of the patients which will be. And if you want to have like from the last dose of temozolomide, a gap of 12 months, hardly any patient of GBM will fall into those criteria. So mostly in such series in which you see that temozolomide has been re-challenged and the DFIs are of more than 12 months, those will be mainly of, as I said, IDH mutation positive tumors, which will be either secondary glioblastomas or anaplastic astrocytomas.
Thank you.
So there are, I think all the questions are answered. If there are no other questions, then I'll hand over to Kumar sir for the Friday discussion with residents. Sir.
Thank you, Nandini, and wonderful presentation, and congratulations to your team, Vijay and you.